Hi, in today's class, we'll be learning about traumatic brain injury and its anesthetic implications. So, just a second. So, the objectives of this class will be we'll know about the physiology, we'll classify the head injuries, we'll also learn about the management of head trauma and the recent brain trauma foundation guidelines, how to intubate in the case of head trauma cases, what are the issues associated in neuroanesthesia, what are the choice of anesthetics, what are the effects of positioning, and emergence from anesthesia. So, in physiology of traumatic brain injury, normally the intracranial pressure is about 10 millimeter of the mercury. So, when it is more than 10 millimeter of mercury, we are classifying it as increased ICP. When the ICP is as high as 22 millimeter of mercury, and if it is sustained and refractory to treatment, it is usually associated with poor outcomes because such sustained ICP will result in herniation of the brain. So, for the basics, we have to learn about the Monroe-Kelly doctrine. So, it states that the total volume of intracranial contents should always remain constant. This is because cranium is a rigid structure which is incapable of expanding. So, as we can see from this graph, when the intracranial volume increases, initially there will be volume compensation of CSF, blood, etc. So after a particular point, this intracranial increase in intracranial volume will not be compensated, which will result in increase in intracranial pressure. So I'm again summarizing. Whenever there is an increase in volume, it will be compensated, which will result in a constant intracranial pressure. After a particular point, this will undergo decompensation and it will lead to increase in increase in intracranial pressure, which may lead to herniation. So, what are the contents of the cranium? The foremost content will be the brain. The other contents will be CSF, arterial volume, and venous volume. As we can see, this is a rigid compartment. It cannot expand. So, increase in the one compartment will be compensated by decrease in the other. For example, consider a compensated state. In the brain, there is a mass. Because of this, there is an increase in volume. This will be compensated by CSF and venous outflow. So here ICP is maintained normally. When the mass keeps on expanding, that is the volume keeps on expanding, then there occurs decompensation, which will result in increase in the case of ICP. So this is a flow chart depicting what are the contents of the cranium and how increase in each content will affect it. So the main four contents include blood volume, CSF volume, cellular compartment, and fluid compartment. Blood volume includes both arterial as well as venous compartment. So, in the cellular compartment, what are the causes of increase in cellular compartment? Mainly mass lesions. These include tumor, hematoma. The hematoma may be subdural, extradural, or it can also be intracerebral. Increase in the CSF volume can also be a cause of this. The other is fluid compartment, that is cellular compartment. That is whenever there is cellular edema, that will be increase in the intracranial volume. So, most important factor is the blood volume. So, what are the factors which affect blood volume? Whenever there is increased airway or intrathoracic pressure, there will be increased jugular venous pressure because normally blood is drawn into the thorax due to the negative intrathoracic pressure. Whenever there is a positive pressure ventilation or increased airway pressure which occurs due to obstruction, there will be decreased blood flow to the lungs. So there will be pooling in the right side of the heart. This results in increase in the case of JVP. Another is PaCO2. PaCO2 is nothing but partial pressure of carbon dioxide. Whenever there is hypercapnia, there will be increased blood flow to the brain. Next is decrease in the case of PaCO2, that is hypoxia. Hypoxia is also a stimulant for cerebral vasodilation. As a result of this, there will be increased blood flow to the brain. Certain drugs also affect the blood volume. Examples being some anesthetics, which will be explained later in this topic, vasodilators, and seizures. These will also lead to increase in the case of cerebral blood flow, which results in increase in cerebral blood volume. So, as a result of increase in either one or combination of these, there will be increase in the case of intracellular volume. So, as the intracellular volume increases, there will occur compensation according to Monroe-Kelly doctrine. But once the compensatory mechanisms are exhausted, then increase in the case of intracranial pressure will rise. Because of this, there will be herniation or decrease in perfusion pressure, which will result in stroke. So initially there will be decrease in BP, then there will be followed by compensating increase in BP. So whenever there is increase in the intracranial pressure, the patient will present with bradycardia, hypertension, and irregular respiration. This triad is called as, someone can answer. This triad is called as, we'll discuss at the end of the topic. Okay. Then cerebral blood flow. So cerebral perfusion pressure, what is cerebral perfusion pressure? It is defined as the mean arterial pressure minus intracranial pressure. That is, cerebral perfusion pressure is equal to mean arterial pressure minus intracranial pressure. So whenever the mean arterial pressure lies in the range of 50 to 150 millimeter of the mercury, there will be a constant cerebral blood flow. That is, the concept is, even though the BP keeps on varying, the cerebral blood flow should remain constant. But this will occur only in the map of 50 to 150 millimeter of the mercury. That is, auto-regulation will happen only in this interval. Here you can see between 50 and 150 millimeter of the mercury, the cerebral blood flow remains constant. When the map decreases less than 50, the cerebral blood flow falls. Also, when the map increases more than 150, the cerebral blood flow will increase, which will result in injury to the brain. Okay. So how to classify head injuries? We are classifying head injuries based on the severity or based on morphology. So based on the severity, we are classifying injuries as mild, moderate, or severe. So all this classification is based on GCS. So in mild, the GCS will be 13 to 15. In the case of moderate, the GCS score will be 9 to 12. In the case of severe, the GCS score will be between 3 to 8. So what is GCS? We'll see it in the next slide. So based on morphology, that is where this fracture occurs or where the injury occurs, we can classify it. We can classify head injury as either skull fractures or intracranial lesions. In skull fractures, either the vault may be involved or the basilar structures may be involved. In vault fractures, it can be linear or stellate, but that can be, the vault fractures can also be depressed fractures, or they can be non-depressed fractures. That is, there will be a fracture, but the fracture segment will not be displaced. Then in basilar is nothing but the floor of the skull. So in basilar fractures, they are classified as, the patient can have either with or without CSF link, with or without seventh nerve palsy. So in the case of intracranial lesions, we are classifying it as either it is localized to one point or whether it is diffuse. So if it is localized to one point, it is called as focal. So focal is classified into epidural, subdural, intracerebral. So epidural is a space which is present outside the dura. That is called as epidural. Subdural is between, what is subdural? Yeah. Subdural is nothing but it is a space between dura and arachnoid. Okay. Then it is either intracerebral, that is within the pia mater. That parenchyma of the brain may be affected, that is intracerebral. Then there is diffuse injury. In this diffuse injury, there will be widespread injury of the brain. So they are classified as, there may be concussion, there may be single concussion to one hemisphere or something like that. But there may be multiple concussions throughout the brain. And they can also be classified as hypoxic or ischemic injury. This usually occurs due to hypoxia or either due to decrease in the case of blood flow to the brain. Other is axonal injury. So what is Glasgow's coma scale? Glasgow's coma scale, it is an initial method which is used for assessing the neurological status of the patient. So in this, we are going to assess three factors. One is eye opening, next is verbal response, another one will be motor response. So the total score will be, we'll write it as E4, V5, M6. So eye opening, E4 is the patient opens eye spontaneously. E3 is the patient opens the eye only to speech. E2 is the patient opens the eye only to pain. And the last E1 is the patient will have no response. So when you write the GCS as E1, the patient is not responding either to any stimulus, painful stimulus, or any to verbal command. That indicates that E1. Okay. So verbal response also, we can classify it as 5. So V5 is, if the patient is intubated, you always have to write the verbal responses VT. That is, the patient cannot, we cannot assess the verbal response because the patient is intubated. Okay. So in verbal response, E5 is the patient is oriented. That is, you will ask the patient, what's your name? Can you identify where you are staying? What's the date? That is, the patient is oriented to time, place, and person. The next response, E4 is sentences. That is, the patient will be mild disoriented, but he'll speak in sentences. Then E2 is the patient will be disoriented. E2 is I'm sorry, I'm repeating. E5 is patient is oriented. E4 is the patient is mild disoriented, but he'll speak in sentences. E3 is the patient will produce irrelevant words. E2 is the patient will make incomprehensible sounds. That is E2. What is E1? E1 is the patient is not responding. So you are speaking to the patient, you are giving any painful stimulus to the patient, even though if the patient is not responding, that it is V1. Okay. So motor response is 6. So M6 includes the patient is obeying commands. For example, if you are asking the patient to lift your leg or lift your arm, if the patient is obeying those commands, it is called as M6. So what is M5? M5 is localizes the pain. For example, if you are giving a pain stimulus in the suprasternal area, the patient will move the hand to the suprasternal area. That is called as localizes pain. M4 is flexion or withdrawal to pain. That is when you are in this case also consider, for example, in this case you are considering you are applying a painful stimulus to the suprasternal area. Okay, but the patient will not raise his arms to the suprasternal area. That is, he will not localize to the pain, but there will be flexor response or withdrawal response to the pain will be present. M3 is abnormal flexion to pain. M2 is extension to pain. M1 is no response. So M3 is also called as decorticate. M2 is also called as decerebrate. Okay. So, just a second. So first, if the patient is presenting with head injury, the first and foremost in everything is history taking. So we ask history. For example, what is the name of the patient, age of the patient, sex of the patient, race, occupation. So mechanism of injury. How did the injury occur? Did he fall from the height, or was there an RTA, or was there an blunt injury? So we ask the mechanism of injury, time of injury. When did the injury occur? For example, it just occurred, or it occurred a day before. How long has the injury occurred, and how was the patient's GCS or neurological status after that injury? So loss of consciousness immediately post-injury. So loss of consciousness is an important predictor of head injury. So if the patient is saying, if the patient is having a loss of consciousness, you will have to ask for how many duration the patient had loss of injury, whether any associated ENT bleeds or patient had any seizures, you also have to elicit this. So next is subsequent level of alertness. If the patient had any amnesia, amnesia can be classified as retrograde or anterograde amnesia. You also have to ask for that. Next is headache. Headache is either mild headache, moderate headache, severe headache, and vomiting. So most of in history, most of the important clinical features which elicit which determine if the patient has a head injury is loss of consciousness, any level of what's the level of alertness of the patient, any headache, vomiting, or seizures. So first we are dealing with the mild head injury, that is GCS to 13 to 15. Now we have asked history. So after history is always general examination. First you do the general examination, because you also have to elicit if there is any other injury to the patient. Then limited neurological examination you do, followed by cervical spine and other x-rays as indicated by the history or signs elicited during general examination. Next, we have to do blood alcohol level and urine toxicology screen. Okay. So there is a criteria whether we should take any CT scan for head injury or not. So CT scan is only indicated for high or moderate risk of neurosurgical interventions for present. For example, so if there is any, so CT scan is indicated only you are suspecting a major or severe head trauma. In other cases, there is no need to do a CT scan. Okay. So after taking the CT scan, you will determine whether you have to transfer the patient to appropriate facility or to discharge from the hospital. So what is the criteria for discharge? If the patient does not meet any criteria for admission, you will discharge from the patient. So then arises the question: what is the criteria for either admitting the patient, or if you are a secondary care system, then what is the criteria for transferring the patient to other areas? So if the patient has abnormal CT scan, if it has any penetrating head injuries, if the patient has prolonged loss of consciousness, or the GCS is deteriorating from the time of admission, patient has severe headache, and if there is any alcohol, drug intoxication, if skull fracture is present, says of it can be either rhinorrhea or otorrhea. But if there is significant associated injuries such as hemopneumothorax or cardiac tamponade, if there is no reliable companion at home, and if there is abnormal GCS that is less than 15, persistent focal neurological defects is present, then if these factors are present, then you'll admit the patient or you either transfer the patient to a higher care facility. So if these criteria is not met, then you will discharge the patient. So I'm again paraphrasing. So the patient is first presenting, patient is presenting with mild head trauma. What is the criteria for mild head trauma? This is between 13 to 15. So in such cases, you'll always elicit history, basic details about the patient, any history of head trauma, including loss of consciousness, headache, vomiting, etc. We'll do a general examination, systemic examination, rule out any other injuries, and CT scan is warranted only if the patient has severe or moderate head injury. Then, if these features are present, then you will admit or either transfer the patient. If they're not present, then you will discharge the patient. Okay. So, what are the indications for CT scanning in patients with mild traumatic brain injury? As I've already said, only when you're suspecting a moderate or severe head injury in mild TBA, then only you will do CT. So, there is also criteria for doing CT. So, head CT is required for patients with suspected mild brain trauma, example, witness loss of consciousness, definite amnesia, or witness, this is important, witness disorientation in a patient with a GCS score of 13 to 15, and any one of the following, which is so these have to be present, plus any one of these following factors have to be present. So high risk for neurosurgical intervention include GCS less than 15 and 2 hours after injury. That is, even after 2 hours after injury, patient is having GCS of less than 15. Suspected open or depressed skull fracture, any sign of basilar skull fracture, example, hemotympanum, recognized, CSF otorrhea, rhinorrhea, Bartle sign, etc. Vomiting, more than 2 episodes, age more than 65 years, because these patients are more prone to develop head injury. Anticoagulants use because there is a risk of bleeding. Moderate risk of brain injury on CT include loss of consciousness more than 5 minutes, amnesia before impact, that is more than 30 minutes, dangerous mechanism, example, pedestrian struck by motor vehicle, occupant injected from motor vehicle, fall from height more than 3 feet of stairs. So if there is any high risk and moderate risk, we have listed the examples also. In these cases, we will do CT in the mild traumatic brain injury patients. Okay. So moving on with moderate brain injury. So what is moderate brain injury? Moderate brain injury is nothing but GCS between 9 to 12. So that is the definition. Okay. So always initial examination is important. Same as for mild head injury plus baseline blood work you will do. CT scan of the head is obtained in all cases. In mild TBA, we are doing it only in certain cases. Here we are doing the CT scan in all the cases. So we are admitting or transferring the patient to a facility capable of definitive neurosurgical care. So after admission, what are you going to do? We are going to take frequent neurological checks, follow up CT scan if condition deteriorates, or preferably before discharge. So we can classify the responses to if the patient improves, that is which will occur in about 90% of the patients. We can discharge them whenever we feel appropriate, and we can ask them to follow up in clinic. So if the patient is deteriorating, that is which will occur in about 10% of the patients. So if the patient stops following simple commands, that is the GCS becomes poor, repeat CT scan and manage as per severe brain injury protocol will be started. So this is the protocol for moderate brain injury. Okay, so in moderate brain injury, patient is coming, you're eliciting the history, and we will do the initial examination, systemic examination, look for other injuries. We'll definitely do a CT scan, and after this, we will definitely admit the patient and we'll watch the patient with follow-up CT, follow-up neurological examination. And if the patient improves, you can discharge, or if the patient doesn't improve, we can do with, you can treat as severe brain injury protocol. Okay. So, management of severe brain injury. What is severe brain injury? The GCS between 3 to 8 is called as severe brain injury. So, what is the definition? Patient is unable to follow even simple commands because of impaired consciousness. That is, GCS is between 3 to 8. So, how will you assess and manage? First, ABCD is what is ABCDE? That is a primary survey. A is airway, B is breathing, C is circulation, D is disability, is exposure. That is the primary survey. Primary, as I already said, primary survey and resuscitation, secondary survey and ample history. Secondary survey is nothing but ample. Then admit or transfer to a facility capable of definitive neurosurgical care. That is, if you have the facility to treat the patient there, you can keep the patient there. But if you feel that the patient should be referred to a higher center, never hesitate. Shift the patient to a higher center. Then we start with therapeutic agents, usually administered after consultation with the neurosurgeon. So what are the drugs we'll give? Mannitol. So what is mannitol? Mannitol is an osmotic diuretic which is given to decrease the ICP. Next is avoid hyperventilation in the first 24 hours unless signs of herniation. So what does hyperventilation do? Does anyone remember? What is for this? We have to understand the correlation between PaCO2 and cerebral blood flow. So PaCO2 is partial pressure of carbon dioxide. As you have said in the previous slide, whenever there is hypercapnia, the cerebral blood flow will increase. So when cerebral blood flow increases, intracranial pressure will also increase. Okay, so this is the concept. So initially, it was said that when the patient presents with a traumatic brain injury, you can hyperventilate the patient because hypocapnia will decrease the cerebral blood flow, which in turn will decrease the intracranial pressure. But this is not advised nowadays uh, because of the injury, there may also already the patient may have some ischemia in the brain. So if you're further reducing the cerebral blood flow behind the cutoff, then cerebral ischemia will occur. So hyperventilation and associated hypocapnia is advised only when there is if there is signs of imminent herniation. That is, you're seeing that if I don't intervene now, the patient is going to herniate. Then only for a short duration of time you can hyperventilate. So what is hypertonic saline? Hypertonic saline is also a diuretic. It is usually given in patients in which mannitol is contraindicated. So mannitol, the route of excretion is by kidneys. So in the case of renal failure, you cannot give mannitol. In such cases, you can go for hypertonic saline. Then you'll simultaneously you'll go with neurological reevaluation. You'll see the GCS, eye opening, motor response, verbal response, pupillary right response, and focal neurological examination. So the patient is presented. We have classified the injuries. There are several methods available for classifying. We are classifying on the basis of GCS into mild, moderate, and severe. So after classification, we have to deal with management, right? So there are several protocols associated for treating traumatic brain injury patients. The most commonly followed is Brain Trauma Foundation guidelines. Okay, so we'll deal with this. So decompressive craniectomy. So decompressive craniectomy means bifrontal decompressive craniectomy is not recommended to improve outcomes. Just a second. So we are not doing bifrontal decompressive craniectomy anymore. We are doing a large frontotemporal parietal, that is FTP decompressive craniectomy, which should not be less than 12 into 15 centimeter or 15 centimeter diameter. Is recommended over a small FTP DC for reduced mortality and improve neurological outcomes in patients with severe PBA. That is, don't do bifrontal DC. DC is decompressive craniectomy. You are going to do a large FTP decompressive craniectomy. The size should be about 12 to 15, 12 cross 15 or 15 centimeter in the case of diameter, and evacuate the hematoma. Okay. So prophylactic hypothermia, if it is given early, that is 2.5 hours. For short term, 48 hours post injury, prophylactic hypothermia is not recommended now. So this is the recent guidelines. So now they are not recommending prophylactic hypothermia. What about hyperosmolar therapy? Mannitol is very highly effective for control of raised ICP. So what's the dose of mannitol? 0.25 to 1 gram per kg body weight. Arterial hypotension, that is systolic blood pressure, less than 90 millimeter of mercury should be avoided. So if you are going to give mannitol, there will be like a osmotic diuresis. So the cerebral edema will decrease, but because of diuresis, the BP may fall. So the BP systolic blood pressure cutoff should be 90 millimeter of the mercury. We should not allow the BP to fall below this level. Okay. So restrict use of mannitol prior to ICP monitoring to patients with signs of transtentorial herniation or progressive neurological deterioration not attributable to extracranial causes. So CSF drainage. external ventricular drainage system zeroed at the midbrain with continuous drainage of CSF may be considered to lower ICP burden more effectively than intermittent use. Use of CSF drainage to lower ICP in patients with an initial GCS of less than 6 during the first 12 hours after injury may be considered. So if your ICP is ICP is raised due to increase in the CSF, then you can consider CSF drainage. So ventilation therapies, as I've already said, prolonged and very severe hypocapnia is not advised now. This is only explained in this point. That is prolonged prophylactic hyperventilation with PaCO2 of less than or equal to 25 millimeter of mercury is not recommended. So when you are going to provide hyperventilation and hypocapnia only as a temporary measure for reduction of elevated ICP. So hyperventilation should be avoided during the first 24 hours after injury when cerebral blood flow is often reduced critically. So if hyperventilation is used, SjO2 or BTPO2 measurements are recommended to monitor oxygen delivery, because if you are going to hyperventilate, hypocapnia, which will result in decrease in cerebral blood flow, which may provoke cerebral ischemia in already traumatized brain. So these oxygen measurements are necessary. Steroids, in steroids, the use of steroids is not now recommended for improving outcome or reducing ICP. In patients with severe traumatic brain injury, high-dose methylprednisolone was associated with increased mortality and is contraindicated. So, steroid is not routinely advised for traumatic brain injury. So, for seizure prophylaxis, that is level 2A. So, prophylactic use of phenytoin valproate is not recommended for preventing late PTS. Phenytoin is recommended to decrease the incidence of early PTS, that is within 7 days of injury. PTS is nothing but post-traumatic seizures, when the overall benefit is thought to outweigh the complications associated with such treatment. However, early PTS have not been associated with worse outcomes. At the present time, there is insufficient evidence to recommend levetiracetam compared with phenytoin regarding efficacy in preventing early PTS seizures and toxicity. So, what are the drugs we are using? Most commonly using is phenytoin or valproate. Okay. So, nutrition, feeding patients to attain basal caloric replacement at least by the 5th day or at most by the 7th day post-injury is recommended to decrease mortality in level 2B, level 1A, level 2B, or the level of evidence. Okay. Transgastric jejunal feeding is recommended to reduce the incidence of ventilator-associated pneumonia. So, DVT prophylaxis, these patients are going to be bedridden or non-ambulant for a long period of time. So, DVT prophylaxis is highly important. Low molecular weight heparin or low dose unfractionated heparin may be used in combination with mechanical prophylaxis. However, there is an increased risk of expansion of ICH. In addition to compression stocking, pharmacological prophylaxis may be considered if the brain injury is stable and the benefit is considered to outweigh the risk of increased ICH. There is insufficient evidence to support recommendations regarding the preferred agent, dose, timing of pharmacological prophylaxis for DVT. So, if you are for DVT, what we are going to do? We are going to give anticoagulants. So, when the patient is already having head injury, which is bleeding, which you are suspecting that it has increased in size, if you are going to give an anticoagulant, then the size of the intracranial hemorrhage will increase, right? So, only we suspect that the size of the bleed is constant, and only when the benefit outweighs the risk, you will always have a risk-benefit ratio. If the benefit is more, then you will give an deep vein thrombosis prophylaxis. But this is only for pharmacological agents. DVT prophylaxis is very important. If you are going to suspect that the brain injury will increase, you can go with mechanical prophylaxis such as compression stockings. Okay, it can give compression stockings for all patients. Pharmacological intervention only is depending on risk-benefit ratio. Then monitoring, ICP monitoring. Management of severe traumatic brain injury patients using information from ICP monitoring is recommended to reduce hospital and 2-week post injury mortality. Recommendation from the PIR, that is 3rd edition, not supported by evidence, meeting correct standards. Okay. Then CPP, what is CPP? CPP is nothing but cerebral perfusion pressure. So, do you remember the formula for CPP? CPP is nothing but mean arterial pressure minus intracranial pressure. So, management of severe TBI patients using guidelines-based recommendation for CPP monitoring is recommended to decrease 2-week mortality. So, CPP we are recommending. Advanced cerebral monitoring, jugular bulb monitoring of AVDO2 as a source of information for management decisions may be considered to reduce mortality and improve outcome at 3 to 6 months post-injury. Okay. So what are the thresholds? BP threshold is systolic blood pressure at more than 100 millimeter of mercury for 50 to 69-year-olds, at 110 millimeter of mercury or above for patients for 15 to 49 years old. So intracranial pressure threshold is ICP less than 25 is recommended. Okay. So how will you intubate the patient? How will you intubate a head injury patient? So patients with, just a second, we'll do this. Okay. So patients with GC score of 7 to 8 or less require tracking intubation and controlled ventilation for ICP or airway control or both, right? So patients with severe traumatic brain injury may also require intubation because trauma-related cardiopulmonary dysfunction. So what are the problems encountered? There will be elevated ACP, elevated ICP. The patient will have a full stomach, and the cervical spine status will be uncertain. The RA status will be uncertain, and we cannot know about the volume status. For example, if the patient has a severe bleed, then the patient may already present with hypotension. The patient may be uncooperative or combative because of any ischemic injury to the brain or because of any drug consumption, and hypoxia. Hypoxia will also, if the patient is having hypoxia, he will always be irritable. Okay. So we'll always follow with ABC of resuscitation, securing the airway, guaranteeing gas exchange, and stabilizing the circulation or the high initial priorities than ICP. So cervical spine stabilization. This is a photo which is showing inline stabilization of the spine. So there is one anesthetist. He is standing at the head end of the patient and is stabilizing the neck. Okay. The another anesthetist will be there who will be intubating. Okay. And another one is used for external engine manipulation if needed. Okay. So what are the issues in neuroanesthesia? We have to control the intracranial pressure and there should be adequate brain relaxation. The management of PSAO is important. Management of arterial blood pressure. What's the use of steroids, osmotherapy, diuretics, when to use anticonvulsants, issues associated with patient positioning, pneumocephalus, venous air embolism, monitoring, IV fluid management, hypothermia, glucose management, and what about emergence from anesthesia? All these factors we have to keep in mind when we are going to take a case of brain trauma. Okay. So, what are the goals of treatment? Clinical parameters. So, systolic blood pressure should be more than 100 millimeter of mercury. This should be more than 65 years of old. In less than 65, systolic blood pressure should be more than 110 millimeter of mercury. Temperature should be between 36 to 38. Glucose should be between 80 to 180 milligram per deciliter because hyperglycemia will increase or aggravate the brain injury. Okay. So hemoglobin should be more than or equal to 7 gram per deciliter. INR should be less than or equal to 1.4. Sodium should be between 135 to 145. PaO2 more than 100 millimeter of mercury. PCO2 between 35 to 45 millimeter of mercury. Just remember, we are maintaining PaCO2 in the normal range. We are not maintaining in the hypocapnic range. Okay. So pH between 7.35 to 7.45. Most commonly, acidosis will occur in these patients. So we always have to maintain a normal pH. The platelets more than 75 into 10, that is more than 75,000 because low platelet count will also aggravate bleeding. So what are the monitoring parameters? CPP should be, CPP cerebral perfusion pressure should be more than or equal to 60 millimeter of mercury. ICP should be between 5 to 15 millimeter of the mercury. So what is the normal intracranial pressure? That is 10 millimeter of the mercury, right? So we should not allow the ICP to rise above 15 millimeter of the mercury. Then BBTO2 should be more than or equal to 15 millimeter of mercury. And always remember the pulse oximetry saturation should be more than or equal to 95%. Okay. So what are factors for control of intracranial pressure and brain relaxation? We have to maintain adequate cerebral perfusion pressure, prevent the herniation of brain tissue between intracranial compartments or through foramen magnum. Clinical features. So, what are the clinical features of increased ICP? Headache, nausea, vomiting, blurred vision, somnolence, papilledema. In the CT, we can see midline shift, obliteration of basal cisterns, loss of sulci, ventricular effacement or enlarged ventricles in the event of hydrocephalus or ventricular tapping and edema. Okay. So, these are the clinical features and these are the signs which you are going to see in CT. So, we have already seen the pathophysiology of intracranial hypertension. I have already explained this. So, how we are going to deal with this pathophysiology, okay? So, intracranial compartments and techniques for manipulation of their volume. So, first there is cells. The cells include neurons, glia, tumors, and extravasated blood. So, in these cases, we can do a surgical removal. If there is fluid, it can be intracellular or extracellular. Diuretics, osmotic or diuretic agents, steroids, principally tumors is given. For CSF, we can increase in ICP due to increase in the case of CSF, we can do drainage. In the case of blood, arterial side, we can decrease the cerebral blood flow. In the case of venous side, we can improve cerebral venous drainage. All these are methods which are used by us to decrease ICP. Okay. Is this clear or should I explain again? Okay. So what are the four compartments that are present in the cranium? That is cells, fluid, CSF, and blood. So if the cells, what is the cause for increase in ICP caused by cells? It may be due to tumor. So if it is a tumor, you can do surgical removal. If it is due to fluid, we can give diuretics. If it is due to CSF, we can cause CSF drainage. If it is due to blood, we can decrease cerebral blood flow and promote drainage. Okay. So, how to reduce brain tissue volume? The methods include tumor resection, abscess removal, steroids, especially dexamethasone to reduce cerebral edema, mannitol or furosemide to reduce intracellular volume, hypertonic saline to reduce intracellular volume, decompressive craniectomy to increase intracranial volume. So, reduce the blood volume, evacuation of hematomas, arterial, the arterial side, you should avoid hypoxemia, hypercarbia, hyperthermia, vasodilated drugs, hypotension, barbiturate coma to reduce the cerebral metabolic rate of oxygen. Because whenever there is a seizure, the cerebral metabolic rate will increase, which will result in increase in the case of cerebral blood flow. So in the case of venous, patient positioning with 30-degree head up, avoiding neck compression, avoiding neck compression with ties or excessive rotation, avoiding PEEP or airway obstruction, and CVP lines in the case of neck. So what are the methods to reduce CSF volume? These include insertion of external ventricular drain or BSP shunt to reduce the CSF volume. This is more of a long-term measure. Okay. So selection of anesthetics. So what are the anesthetics? First is inhalation anesthetics. The inhalation anesthetics have two effects. One is direct effect and another is indirect effect. In the direct effect, cerebral vasodilation with an increase in the case of cerebral blood flow occur. Always remember whenever there is, in the direct effect, there will be cerebral vasodilatation with increase in the case of cerebral blood flow. A reduction in the tension of the isolated cerebral artery muscle will occur. So, what is in the indirect effect? There will be uncoupling of the normal relationship between metabolism and blood flow. So, always remember, whenever the cerebral metabolic rate increases, cerebral blood flow will always, cerebral blood flow will also increase. This is called as coupling. If this is reversed, it is called as uncoupling. This uncoupling occurs in the case of inhalation anesthetics. So, if the mark is more than 1, uncoupling will occur. If the mark is between 0.6 to 0.8, there will be no uncoupling. So, cerebral blood flow, ml per 100 gram per minute, cerebral metabolic rate of oxygen. So, as we can see, shift to the left with increase in mark of inhalation agents because of uncoupling. So, what about isoflurane? Cerebral blood flow and cerebral blood volume are not affected by concentrations in 0.6 to 1.1 mark of isoflurane, but 1.6 mark double cerebral blood flow. So, if you are using isoflurane for a neurosurgery case, always keep the mark at 0.6 to 1.1. Do not increase above this, because if you increase it above this, the cerebral blood flow will increase and the ICP will further increase. Okay, so reduction, it also reduces cerebral metabolic rate. So, isoflurane is a standard volatile agent which is used for neuroanesthesia. Next is sevoflurane. It has low blood gas solubility. It enables very rapid recovery even after many hours of surgery. But the only side effect being compound A, which is formed, which may be toxic, that is nephrotoxic. Desflurane also produces rapid recovery, but it is a irritant with a recurrent tree, and it also requires a special vaporizer. So ether, ether is not commonly used. This is only for theoretical purpose. Okay. So induction is for long. Biphasic response in brain will occur at low concentration. At this 2.4. What is biphasic response? It has two response. So if it is a lower concentration of 2.4, it will lead to reduction in cerebral blood flow and decrease in cerebral metabolic rate. The concentration is more than 4.5%. There will be increase in cerebral blood flow and cerebral metabolic rate of oxygen rising towards baseline value. So it has a risk of epileptic activity. So nitrous oxide, further enables uncoupling, significant increase in cerebral blood flow. This acts synergistically with the volatile agents. So nitrous oxide is not commonly used in neurosurgery, but as such, it is not contraindicated for most neurosurgical procedures, and there is minimal cerebral swelling. So if you're expecting a very high amount of swelling, do not use nitrous oxide. Always use air and O2 mixture. Okay. So hypnotics, flow metabolic coupling is preserved. That is, whenever there is an increase in cerebral blood metabolic rate, there will be parallel increase in cerebral blood flow. Okay. So barbitrates, it reduces the cerebral blood flow by both direct cerebral vasoconstriction and indirectly by reduction in cerebral metabolism, dose-dependent reduction in the cerebral metabolic rate and blood flow. Thiopentone is used for induction and has been used for maintenance as infusion with nitrous oxide, but without narcotic supplements. Propofol also reduces blood flow, blood volume, intracranial pressure, and cerebral metabolism. So the dose is bolus of 1 milligram per kg and infusion rate of 10 milligram per kg per hour for 10 minutes, 8 milligram per kg per hour for further 10 minutes. This is subsequently reduced to the baseline maintenance of 6 milligram per kg per hour. So initially you're starting a rapid bolus dose of 1 milligram per kg, followed by infusion of 10 milligram per kg per hour, decrease it to 8, then further reduce it to baseline of 6 milligram per kg per hour. Okay. It is very useful agent for maintenance of anesthesia of the neurosurgical patient, particularly when nitrous oxide is to be avoided. So ketamine increases cerebral metabolic rate of oxygen, cerebral blood flow, and ICP. These changes can be reduced by pre-treatment with hypocapnia, thiopentone, or a benzodiazepine. So ketamine is not preferably used for neurosurgery cases. Neuromuscular blocking drugs, SAXA. It is a depolarizing neuromuscular blockade, increases ICP, but this increase in ICP is only transient. Then the question arises, should we use scopolamine for neurosurgery case? Yes or no? The answer is, if you feel that it is going to, because most of the head injury cases will be difficult airway cases because associated airway trauma, right? So if you are feeling that I cannot intubate this patient using a non-depolarizing muscle relaxant, and if your only scopolamine is available, then scopolamine is preferably used for neurosurgery cases. But if you see that the airway of the patient is good, if there is no any blood aspiration, then you can go with non-depolarizing muscle relaxants, preferably rocuronium. Vecuronium, there is no significant effect on cardiovascular parameters, no effect on intracranial pressure or cerebral perfusion pressure. Narcotics will cause an increase in the intracranial pressure only when the airway is not controlled. That is when apnea occurs. Okay. So what will happen if apnea occurs? Airway pressure will increase. As a result of this, cerebral venous drainage will decrease. So intracranial pressure will increase. Okay. So fentanyl, there will be suppression of cardiovascular response to painful stimulus, usually in the dose of 1.5 to 2.5 mics per kg. It usually doesn't have any change in cerebral blood flow or ICP. Okay. Then the other being, so high intracranial pressure, right brain checklist. So first is, are the relevant pressures controlled? That is JVP. First, we have to confirm if these pressures are controlled. So how will you, if there is any blockage or any obstruction to the JVP flow, then intracranial pressure will increase, right? So we have to rule out extreme head rotation, neck reflection, direct jugular compression, head up posture, and second will be airway pressures. If there is any airway obstruction, bronchospasm, straining, coughing, pneumothorax, excessive PEEP or APR ventilation, and also check partial pressure of CO2 and O2. And final will be artery pressure. Next is rate. First is pressure, next is metabolic rate. So is the metabolic rate control? If there is any pain, arousal, seizures, if the patient is febrile, then the rate will be increased. So such factors should be controlled. Are there any potential vasodilators in use? Nitrous oxide, volatile agents, nitroprusside, calcium channel blockers. All these will increase cerebral blood flow. So we have to check whether we are using any of these agents. Then, if there is any unrecognized mass lesions, that is hematoma, R plus nitrous oxide, that is R embolism, CSF, clamp ventricular drain, these have to be ruled out. So for increased intracranial pressure, we use this checklist, which is called as tight brain checklist. Okay. So first being whether the pressures are controlled. Second is metabolic rate. There will be use of any potential vasodilators, and fourth will be mass lesions. Okay. So methods for rapid reduction of intracranial pressure and brain volume. So we can reduce PaCO2, but not less than 23 to 25. We can allow for CSF drainage, diuresis, cerebral metabolic rate suppression, MAP reduction, surgical control. Okay. So CPP should be maintained at normal or even high normal levels after acute central nervous system insults and during most intracranial neurosurgical procedures. Okay. So positioning, pressure point should be padded. Pressure and traction on nerves must be avoided. Graded compression stockings and sequential compression devices can be used. For intracranial procedures, head-up washering is used to optimize venous drainage. The conspicuous exception occurs with the evacuation of chronic subdural hemorrhage, after which patients are usually nursed flat to discourage reaccumulation of fluid. Okay. So, what are the positions available? Horizontal position, launch and position, reverse limber position. What about fluid management? We have to maintain normal volume, avoid detection of serum osmolarity. So, normal saline with an osmolarity of 308 millimosmoles and balanced wall solutions are the fluids which are most commonly used. And if they are infused in large doses, hypochloremic metabolic acidosis can occur. Lactated ringer, that is RL, has an osmolarity of 273. It can be used alternatively with NS. Plasmonic can also be used. So colloids, 4% albumin solution was used. 4% albumin solution used was hypoosmolar. It aggravated the edema. Therefore, colloids, they're not routinely used for the case of traumatic brain injury patients. Okay. So emergence from anesthesia, if the patient is having GCS more than 13, smooth emergence is always advised. That is, the patient should be free of coughing, straining, arterial hypertension. Because when arterial hypertension occurs, intracranial bleeding will increase and there will be increased edema formation. Okay, so coughing and straining, the mechanism which I have explained, I have written here. Coughing and straining, there will be sudden increase in intrathoracic pressure, increase in both cerebral, arterial, and venous pressure, which will lead to edema formation, bleeding, and elevated ACP. Lidocaine and vasoactive agents, most commonly labetalol and espolirol are used. That is, the beta blockers labetalol and espolirol are used. Other drugs including hydrolizin, enalapril, diltiazem, nifedipine, clevidipine are also used. Administration of dexmet during the procedure or just prior to its conclusion also reduces the hypertensive response. That is, during surgery, the hypertensive response it can occur due to surgical stimulation, inadequate pain of anesthesia, intubation response, extubation response. All these should be prevented. Okay. So opioids are antitussive and depress the airway reflexes. So if the GCS is less than 13, elective post-op ventilation is usually preferred and measures to raise the ICP is continuous. That is the tight brain checklist. Okay. And patient reassessed, and if the GCS improves, then we can extubate the patient. Or if the GCS worsens, the patient will remain in mechanical ventilation. Okay. Thank you.